All right. So first and foremost, midterm is done. Okay. Now we're taking it to the next step. Okay. We are past the midterm. We are now building on to what we are going to be doing in the actual operating room. Okay. It's going to go by fast. Before you know it, we're going to be at finals. You guys are going to be module 4, resumes, the whole 9 yards. Okay. So we have our quote of the week. We're getting into surgical skin prep and draping. We have a Kahoot, and they're going to wrap it all up. But let's start with our quote of the week. So this week quote comes from one of my favorite authors. You may encounter many defeats, but you must not be defeated. In fact, it may be necessary to encounter the defeats so you can know who you are, what you can rise from, and how you can still come out of it, by Maya Angelou. I have often seen and heard the question, if you could change anything in your life, what would it be? And I have to think about this question long and hard. I think about it because I know that the trials, the struggles, the past has made me the person that I am today. I don't even know if even one change would allow me to see things the way that I do today. So remember that those encounters, no matter how large or small, have helped you become who you are today. All right. Onward to chapter 17, surgical skin prep and draping. I have a video that I'm going to be sending you guys of me and one of my coworkers. We did some draping. And so at one of our previous places that we were at. So I'm going to be sending you guys that today just to kind of look at. Keep in mind, um, you'll have the link to the YouTube. It's going to be sent to you guys, blind CC email. I think that's the easiest way. I may send it Moodle. We'll see. Either way, you will get that link this evening. Okay. What are we going to be doing today? Okay, well, we're going to be looking at surgical prep, draping. There's guidelines that you have to follow. There's guidelines for even removing hair. Yes, there is. We're going to talk about it. Surgical skin marking, we're going to talk about it. There are approved antiseptics for surgical prep. We're going to talk about it. But with everything, let's do an introduction to it. Now, before surgery, the goal is to lower the number of bacteria on the patient's skin to prevent infections at the surgical site. Okay. Normally, the skin has harmless bacteria known as normal flora. They don't usually cause us problems on the skin surface. But during surgery, these bacteria can accidentally enter the body and unfortunately lead to infections. So, to help reduce these bacteria, patients are often asked to shower with a special antiseptic soap. We usually tell them to wash with Hibiclens, like pink, at least once the day before and again on the morning of surgery. This soap actually reduces the bacteria on the skin, like that normal flora, lowering the risk of infection during surgery. Okay. So, we get our principles. Sometimes more than one area on the patient's body has to be prepped. Let's say we're doing a skin graft, okay, and we're using the patient's own skin. So let's say we're going to put a skin graft on their face and we're going to take the graft from their abdomen area. So we're going to prep the face as well as the abdomen, okay? We can prep those areas at the same time to save time and ensure a smooth workflow. I will repeat that. When you have two sites, you can prep both areas at the same time to save time and ensure a smooth workflow. You're only going to use materials approved for skin prep. I put on there in front of you, you'll see Raytex and Laps. You do not want to use these. These are not intended for the purpose and can introduce contamination. And you're probably like, what do you mean? Once a patient has come into the room, equipment, sponges, nothing leaves. Okay, you guys will learn this in the lab. These items have a radiopaque strip. So, like, let's say they're in the body, we're doing a count, we can't find it, x-ray comes in, that strip will let us know, hey, we got to get that out. These are not the sponges that we're going to use for the prep. Once the prep is done, we're going to use plain sponges with nothing because ideally the patient's not open. There's no cuts, right? So we can clean the patient off and keep in mind that these sponges right here are countable. So hypothetically, the nurse says, hey, do you have some sponges that you can use? You not thinking, sure, give them 3 Raytex. Okay, Raytex come in packs of 10, labs come in packs of 5. You're doing your count and you've only got 7 Raytex because you forgot you gave 3 to the nurse who threw those out and put them in the trash, right? Now your count is off. So that's another reason why we don't use these sponges with radiopaque strips for our prep. Does that make sense before we move on? Okay. Now, when we talk about prep solutions, certain cases you may need to use a certain prep solution before the main prep. Okay, so there's a prep before a prep, just to help reduce bacteria before the primary skin prep. Motor vehicle accident, where there's a lot of debris. So we're going to clean that patient off. A lot of times the surgeon will come in and start cleaning things off before they're even prepped. Okay. Um, Great example. You have a patient, let's say they fell off a tree. I don't know why they were in the tree, but they fell out of a tree. And then let's say a branch went through their arm. Okay. They had on long sleeves. So that branch went through their shirt. Anything that was on that branch also went through their arm. And now any bugs, anything. So they're cleaning all that off before the prep even starts. The other thing you want to keep in mind is throughout the process, we're maintaining privacy for our patients. So we're going to have drapes that are going to cover as necessary to protect the patient's dignity while performing the skin prep. And a lot of times the patients are asleep, but we're still going to provide them that dignity. Okay. So I talked about Hibiclens. This is that solution that sometimes we'll use. Patients are usually going to be instructed to use um, twice. Okay. Once before, the day before surgery, and then that morning. Again, they're trying to reduce the normal flora on the body so that it doesn't enter the body. Now, when we talk about head and scalp, the chapter talks about sometimes they have to do a shampoo where they're going to wash their hair twice, kind of the same routine. Okay. Trying to get rid of any bacteria from the scalp so that, again, that doesn't enter the surgical site. We also tell them don't use any gel or hairspray. That way so let's say you do all this cleaning and then you go and put gel in it, right? It's going to defeat the purpose. So we tell them not to have anything on them. Now, keep in mind that your skin is your primary defense against infection. Why do we do the prep? We want to prevent SSIs, okay? Plain and simple. SSIs can occur when bacteria from the skin enter the surgical site. A common cause of these infections is Staphylococcus aureus, which is a bacterium often found on our skin. So we reduce bacteria on the skin. Okay, the skin prep serves as that primary defense, significantly lowering the chance of infection. But there are some things that we have to consider. Okay, and I'm a very imaging person. Allergies. One of the first things that you're going to notice before the prep is done, does the patient have any allergies? A lot of times we write the allergies on the chart in the room, on the board. You got to be careful with certain chemicals. Chemical burns can happen if the prep solution pools under the patient during the procedure. So they're doing the prep. And when we talk about pooling, let's say you look at the flanks of your sides. Okay. And if the person doing the prep isn't careful, it just sits and pools in certain spots. Okay. To avoid this, we just have to make sure that the solutions are applied carefully. And we're going to show you how to dry the patient to check for pooling to make sure there is none. The other thing to think about is alcohol-based solutions. They can be flammable, right? So we're extra cautious when using these around heat sources, open flames, because they can cause fires. Another problem could be thermal burns. Iodine should not be heated in closed containers. We don't usually heat it anyway, but it can lead to thermal burns. Hair removal is another one. So, hair removal for surgery should only be done when a physician orders it. It's not always necessary, so verify with your surgeon before we even do it. We do in cranies, we'll take the hair off and we'll save it and give it back to the patient. That's one time we normally really will, like, especially if we have to get to the brain, we have to get to the cranium, so we will shave it and again, save it and give it back to the patient. But timing is important. Hair removal should be done as close to the surgery time as possible to reduce the chance of infection from any hair or skin irritation. Different methods. Razor, this is going to be specified by the physician. We normally use clippers, which is what you see in the slide. This is the most common one we use. And the cream, if it's allowed. I honestly have not used the cream in the operating room. And keep in mind, in the military, we did the preps, but I've used the razor, I've done the clippers. Okay. Now, again, we talk about location. The hair should be removed in an area away from the surgical site to avoid contaminating the surgical field. And you're going to properly dispose of these. These are going to be single use. We're not going to be trying to sterilize it and use it on someone else. These are going to be single use. The other thing to keep in mind is we never remove eyebrows or eyelashes unless specifically ordered, because this is typically not necessary and can honestly cause irritation or injuries. Now, we're getting closer and closer to being in the operating room. So we look at skin markings. We want to prevent wrong site, wrong surgery, wrong procedure, wrong persons. This is going to be important to just make sure the surgeon operates on the correct area. The surgeon is responsible, I have seen this question, for making the surgical site before the procedure starts. It's important because it confirms the correct location of the surgery. But everyone in the operating room has a voice. There are many times where patient is coming in, they're getting ready to set up the bed, and I've said, "Hey, what side are we doing again?" Oh, you're right. We all are the patient's advocate, okay? But the surgeon is the ultimate responsible individual. The surgeon must use an approved surgical skin marker to make sure that everyone can see, we know what side we're doing, whether it's their initials or a check or something, so that we know, okay, we're doing a left shoulder, the left shoulder is marked. Now, during the skin prep, the circulator has to be careful not to like scrub so hard that they remove that mark, because that's important for correct surgical site identification. Sometimes they have to put in catheters. All right. A urinary catheter may be used to protect the bladder, especially in patients who are unable to urinate normally due to surgery or medical conditions. Sometimes they're in for urology procedures. Okay. A lot of times we want to decompress the bladder. A catheter can help decompress the bladder by just draining any excess urine. The nurse circulator is going to want to keep account of anything coming out of the body. So just keep that in mind. They're going to always monitor output. So we're monitoring how much irrigation we are giving the surgeon to place in the body, and the nurse is monitoring how much is coming out. Okay. We're also making sure we're keeping account on sponges and everything else that are like soiled with a lot of blood too. Okay. But you're going to learn that once you get in the operating room. But there are risks of infection. Urinary catheterization is the most common cause of HAIs in the United States. This makes it so important to use proper sterile techniques and avoid unnecessary catheterization when possible. There are times when the nurse may pass up the catheters to use sterilely and then hand it to them to place it into the patient sterilely. Okay. You also have to think about if a patient's constantly getting these. Repeated attempts at catheterization really should not be done, if at all possible, because you just increase the risk of injury or infection. So if you're unable to pass the catheter, and I know it says in the book, I know we don't normally do it in our scope, but that person or individual should ask the surgeon or another surgical person to kind of help because again, we are the patient's advocate. So we're going to look at a quick video on Foley catheter procedures for female bladder drainage because this will happen in some cases in the operating room, especially if it's going to be a longer case. We're going to place a catheter before the case even starts. So let's take a look.
A urinary catheter is inserted to empty the bladder or to instill medication. Fully expose the urethral meatus. Ask the patient to bear down, gently, and slowly insert the catheter. Advance the catheter until urine flows through the catheter, and then advance it 2.5 to 5 centimeters further. Slowly inflate the balloon, and then seat the catheter by pulling back gently until resistance is felt.
All right. So like I mentioned, a lot of the items that you saw, the nurse will literally hand you the catheter and they'll hand it to you sterilely and you'll hand it back to them. Okay. Again, once you get into the actual lab, it will all come together. All right. The other thing that you'll notice in the operating room is the prep. We have alcohol-based solutions. They are commonly used to reduce bacteria on the skin. The good thing is they do work quickly and effectively, but are often used in combination with other antiseptics to just make sure that everything is thoroughly disinfected. Chlorhexidine, this antiseptic, is highly effective against a wide range of bacteria and is often used for pre-surgical scan preparation. So this is the one that hello, here's the patient. This is what we want you to use the night before and the day of. We have iodophores, such as povidone iodine. So iodophores, think of iodine. They're widely used for skin disinfection. This is the one we normally always use. They are effective against bacteria, fungi, viruses. They provide a broad spectrum of antimicrobial infection or protection, not infection, protection. Okay. This video I'm going to actually send to you guys so you can take your time, dissect it. Now, keep in mind scope practice. Okay. There may be some areas where the nurse may ask you to help. Okay. But again, just keep an open mind when you're going through because it's really important to be able to notice, hey, you missed something respectfully so that you guys can continue to be an advocate for the patient. Okay. Now, with 17.2, we talked about just the basics, but there's supplies that you need. Okay. There are different procedures for skin prep. There's different areas that you will prep depending on the surgical procedure. We still think about patient safety, looking at those allergies. And we look at the skin prep on standard prep sites. Because again, they're going to be slightly different depending on the surgical procedure. So what you see in front of you is some of the items that you will use, you will see. I believe that we will be showing you in the lab just how to do this. You have your surgical gloves, okay? Your towels right here. You have gauze sponges. These are disposable. And then depending on the procedure, you may have forceps, there may be scalpels, skin markers, there may be other things. It just depends. With your antiseptic, you have a scrub and a paint. The scrub uses mechanical use to clean, and the paint uses chemical. Okay, so just think about that. And it says on the bottle which one's the scrub and which one's the paint. With the scrub has to be dried off. The paint does not. So it kind of gives you an idea which one goes on first. Okay. Sometimes they have sterile water used to rinse or dilute. We have cotton tips for the umbilicus. The umbilicus must always be cleaned. Once you get in the operating room, you will become very OCD with certain things. For me, the umbilicus was huge. The very first time that I actually had to clean the umbilicus, what you do is you take the Q-tip, get the solution on, go into the belly button, you're like scrambling the eggs, pull it out. Okay. I was kind of like, whoa. So for me, making sure the umbilicus is cleaned is big. Okay. But that's what those cotton tips are for. That's the first thing you're doing is cleaning out the umbilicus. Um, all of these supplies just help to make sure that you are properly cleaning the prep, okay, the site. All right. Again, you have a scrub and a paint. The scrub uses mechanical motion, so you're actually scrubbing the wound. You're drying it off with the drying towels. These towels are placed on the side sterilely for pooling. So that's how we make sure there's no pooling. Once these towels are, you've patted the skin, you remove them. Then with the solution, you use these to paint. So you have a scrub and a paint. This paint stays on the body. We do not dry the paint off. Okay, it's like that extra barrier. Okay, but sometimes we use a Durapret. Okay, same thing, verifying the patient's the allergies. We make sure if the patient is awake, they're comfortable, properly positioned, because sometimes, yes, your patients can be awake, depending on the case. Explain the skin prep procedure to the patient, just letting them know to reduce anxiety. You're going to let them know you're going to feel something cold and wet. I'm going to clean your skin. Okay. You get all your supplies, your gloves, your towels, your antiseptic solutions, your gauze, everything that you need. And then you want to make sure that everything is sterile and ready to use. When you watch the video, there's going to be a clean and dirty hand. Okay. I want you guys to kind of take notes because there's some things in that video I'm hoping you guys point out. There's supposed to be a clean and dirty hand. Your clean hand grabs your sponge, you pass it to your dirty hand, and you clean with one hand. Psh, toss. Okay. If you don't, if you notice that that's not happening, make sure you send me a message and say, I saw what you're seeing. Okay. Always have a clean and dirty hand. All right. So you have your DuraPrep. The way that this works is you pop the top. Sometimes you can squeeze them depending on manufacturer. In this case, you just pop it down. The solution will kind of go down onto the sponge and then you do your prep that way. Okay. With that, the book talks about common skin prep sites. Okay. When we talk about the eyes, it's going to be the area around the eyes, trying to be careful because you don't want to just put anything in the eye. You don't want to blind the patient. When we do our ears, if you're going in for a cochlear implant or some type of ENT, tympanoplasty, mastoid tympanoplasty, or we're going deep into the ears, you're going to be prepping different things because behind the ears is where we usually get our graft to place inside. Okay. And depending on if you're just doing a tympano or a mastoid being the bone, tympano, you're talking about the smaller bones. Okay. Mastoid, we're going deeper, and then tympanoplasties. Okay. For your face, for facial surgeries, you're going to be doing all of the face coming down. All right. especially when we talk about our neck. When we look at the breast and looking here, so I'm on the same in your thorax, okay? You may go all the way. You're going to go all the way down. The reason I'm saying that is because this plays a big difference on how you drape to how you hand those drapes to the patient or to the surgeon. Your shoulder cases are a little bit different because a lot of times those patients are sitting up. Okay. They're asleep, but we have them in a sitting up position. Okay. And so when we are prepping, you'll have the arm and then you're going to prep all the way down, especially with the arm and hand, the kind of same thing. With the abdomen, they're already laying down. And with the abdomen, you're usually just prepping like that. All right. We look at our flanks. A lot of times our patients may be on the side. If they are already laying on their side, well, of course, we're going to prep them on their side. So this particular slide kind of just breaks it down. Now, that doesn't mean that this entire site we are cutting, right? But this gives us a wider sterile area, okay? More protection. It shows the periphery boundaries of each prepped area, okay? When we do legs or extremities, like let's say you're doing a hip arthroplasty, which is a hip replacement, you're going to have one person holding the leg and then one person prepping all the way. Okay. Those cases, you're going to learn that you're going to want to prep closer to skin incision, like when the surgeon's coming in, because you're holding dead weight. Even arms, sometimes when you're holding them for a while, can just become heavier because you're kind of making sure the only thing sterile on you is gloves. And you're holding, trying to keep that particular extremity sterile. So you don't want to drop it. You want to do anything else like that. Okay. So just keep that in mind because let's say you're a floater and you may be the individuals helping out with that particular prep. Okay. Now we look at possible traumas to skin prep. You're going to hear the term debridement. This may be necessary to remove dead or infected tissue. It helps going to prepare the site. The process can cause trauma to the skin. We've got to get that dead tissue off, okay? Potentially leading to irritation because we got to get all of this tissue that was infected out. Sometimes we will graft the patient. Let's see. I don't have a picture up. Okay, so we have a burn here. Okay, so we're gonna have to graft this. We may take the skin from the thigh usually or a leg, and we're gonna prep this area, obviously, and the leg simultaneously. We'll take the derma mesher. You guys will learn all this, the derma blade. Derma blade takes off that layer of skin, the derma mesher flattens it out, and then they will place that tissue on. So keep in mind, you may have in this case, what is that? 1, 2, 3, 4 wounds that have to be dressed. When we look at heart cases, you're going to prep the skin near the heart, major vessels, and then you have to think about the trauma from the skin can cause irritation, leading to potential complications if the prep solution causes reaction. So you're looking to make sure that the skin is intact. So before you're handing them drapes, you're still looking at the patient. You can do that while you're sterile. Like you're not touching the patient, but you're still looking so that if something does arise, you can tell the circulator, you can tell the surgeon. You never know. You may save the patient from serious injury. Okay. We also have to talk about why we drape a certain kind of way and how do we maintain asepsis during draping. So when you watch that video of me and my coworker, I want you to kind of go back to learning objective 17.3, okay, and kind of watch how we do it. The reason I didn't show it here because I think the video is about 12, 13 minutes. So that's why you guys are going to get it separately. All right. You also have to look at draping techniques. I think we have a video here and how we remove them is very important too. One of the biggest things is you are trying to make a wide sterile area. Okay, that is the purpose. You're making a wide sterile area. I have seen this question highly missed in prior classes, okay? So wide sterile area around the surgical site to make sure the area stays free from contamination during the entire procedure. This protects both the patient and the surgical team. Of course, we're not trying to get infected either. This is one of those times where I want you to be patient and show yourself some grace. Draping can be difficult at first because it requires precise technique and attention to detail. You'll notice in the video that I'm going to send you what we do. Okay. And this is the key. This is where you have to be a little bit more humble. In the video, if someone said, like, you'll hear someone say this part was contaminated, and you, with your naked eye, you're probably like, that wasn't. But this is the thing. If someone is to tell me that part's contaminated, I'm going to, okay, let's fix it. Because at the end of the day, it's about the patient, and we can't see everything. Okay. The biggest thing is maintaining accept technique. Your drapes do not fall on the ground. You're gonna see everything. All right. The size and shape of the surgical drapes is going to depend on the procedure. And the cool thing is our drapes have little people on them. So when you first get the drape, you'll have the head like a body. So you'll know how to hand that drape normally to your physician. Have a couple different drapes. Remember, we have a lot of different procedures from hip replacements to craniotomies, to shoulder cases that use arthroscopy, which is water and scope. Like, so they're going to have pouches to collect fluid. Okay. There's cotton style synthetic blends. We have bonded synthetic. They're non-woven drapes that we use in the operating room. If you're at a smaller facility, you may have cloth. You may not have disposable, and vice versa. Now, each of these materials has specific uses in surgical procedures, depending on the type of surgery, the need for like absorbency, those big ortho cases that have like knee scopes and stuff where there's a lot of fluid. You want a heftier um, drape that has different pouches, and you'll see them. Okay. Especially when you do your first hip and you realize that the drapes come separate and you're connecting all the different drapes because you want to protect everyone from slips and falls and the patient. Again, you may have a regular sheet. Okay. There's a certain way that we hand the drapes to the surgeons as well. You're going to learn it all. Here, you're just going to get familiar with what the drapes look like. Hand towels. This is your number one go-to. We love hand towels as surgical techs. Okay. Love them, love them, love them. We talk about fenestrated, just has a hole. Okay. For whatever reason, a lot of times our eye drapes will have a opening for the eye. Our ear drapes is just a hole where you can kind of work with. We have incision drapes. This is your typical abdominal drape. Half sheet, towels. Sometimes doctors use clips, non-traumatic clips. They place the towels around, the drape goes on, and this they cut through. It's an incision drape. It's a part of the drape, okay? Has an additional layer. You also notice that this one has areas for instruments, okay? That's what these little extra pockets are for. And it just depends on the facility. So, we have a couple videos on how to hand the drapes. Biggest thing, move with a purpose. If you don't remember anything about draping, setting up your sterile field, make every movement count. You kind of visualize what you're going to do, set yourself up, and then move with a purpose. This is not only going to make you much faster, believe it or not, but it's going to help you get mentally organized. Remember, it's all muscle memory. Once you have visualized what you're going to do, you execute, and then you step back, and then you're ready. Okay. So let's take a quick look at this particular video.
Hi, okay, this competency is after you gown and glove your surgeon, which is Candace here. We are going to move on to draping. So we're gonna drape as if this is an appendectomy with a laparotomy drape. I'm starting with the squaring off. What you see here is the 4 towels. There's gonna be 2 different ways to do this. With 4 towels, I'm gonna hand off 1 at a time. See that how I'm holding all 4, but I'm handing 1 at a time. Now I get the other one ready. While Candace puts that on, and we do the same thing for all 4. And then, I don't know, do you want to keep going through? Mm-hmm. Okay. Okay, now what you're gonna see often, may I come on over here? What you're gonna see often is the paper disposable drapes. So you'll have 4 stickies. The best way to do this is 1 at a time. I'm gonna take 1 sticky and remove and hand. While the surgeon's doing that, now I'm gonna get the other one ready. Keep going, just 1 at a time so they don't all get stuck together. Okay, last one. We're then gonna move to our 3/4 sheet, and this will be used as a down sheet. I grabbed it like a book. This is the folded end here. I have the open end, that's in my right hand. I'm gonna open this up to the center. So there's a lot of areas that you can open this, but you need to go right to the center where we have these 2 ends here. I'm gonna hand 1 end to Candace. We cannot come too low. I don't wanna contaminate. And then I'm gonna take the other end on my side. See how we're still hovering above. We're gonna pull 1 end out, and like at Candace's nice cuff there, you're gonna make that cuff every time you're putting a drape down. Big important thing, do not follow this drape down. See how low I am? When we came here, we let it go. Okay, you don't wanna drop too low. Now we go to our lap sheet. You see the adhesive here. I'm gonna ask my surgeon, would you like me to remove the stickies or keep it on? Remove the stickies. So I'm gonna take that off. That's garbage. I'm making a pile of garbage here. I'm holding it again in that same book position with the fold or the spine of the book that's gonna go on to the patient. You can see there's always gonna be a picture that tells you which way is the head and which way is the foot. Can you see that, man?
Yep.
Okay. So now I rest it over our incision. The surgeon's gonna take their half. Again, we wanna make sure that we're not coming in the wrong spot. We wanna come in the center there. You can see the 2 arrows. Now we're doing that same movement, pulling them away from the patient. Where am I? We going up or down first? Down. Okay, down. Now, bring it all the way down and drop. Come up here. When you go to put up, I want to make sure that you have a cuff here. Okay? Your hand has to be within that cuff. The reason for that is anesthesia is behind there and is going to grab that drape from you, and you don't want your hand exposed for them to grab. So we're considering that whole area unsterile. We're staying inside, okay? We're gonna drop it now because we don't have anesthesia. Okay, at this point, the surgeon is...
All right. As I don't want to go too far, what questions do you have with that video? Was that pretty clear as to how they did it? What questions do you guys have before we move on? None? Okay. Okay. If something does come up, let me know. The biggest thing is, yes, that is a lot of drapes, and that is, well, that's average. So like I mentioned in what I typed in, you're not going to have both blue towels or sticky. You're not going to have both. You'll have one or the other. You're either going to hand the surgeon blue towels or stickies. Yes, they are. Um, you always want to avoid. So the question is, are the sticky bits really sticky? Like, should we avoid touching the strips when we're gloved? Yes, you're going to want to avoid. It's not going to stick to the point where your gloves will tear, but it just gets a little annoying. So when I do it, I grab the tips. Like I'll take off the strip and then I'm kind of grabbing on the two tips. Is there always labels inside that indicates the head from the feet? Yes. Great question. Yes, they are. They are. Not to intimidate you, but there are times where we have to drape instruments. And so if you've had the opportunity to print out this PowerPoint, you were probably like, oh my goodness, do we drape this? Yes, we do. We drape the microscope. We drape C-arms. We drape the robot um, appendages. I guess that's how you say it. And this happens before the surgeon usually comes into the room. So again, this is where you show yourself some grace. Even those of us who have been doing cases, um, this can be a little bit daunting because you have eyepieces. You have to make sure that you do not contaminate. You're going over. So normally what we'll do is I will take the microscope glass part, everything's sterile, kind of wrapped around my arms. I'll click it up to the bottom here and then kind of roll it over. I'll pull the microscope down, kind of like out and down, so it's still sterile. And then I will make my way around. Once I get to like this part right here, the nurse takes it. So that part back there is not sterile. What we are trying to make sure is sterile from here. Once you have the glass part on, you can kind of adjust it to get it to the eyepieces. Again, the very first couple times you do it, can be a little bit intimidating, but normally your preceptor will be there with you. And then when you get to your new sites, when you get to your jobs, you're going to be precepted. And especially if you're doing like a lot of ENT and a lot of neuro cases, it'll be like second nature. If you're doing a lot of ortho, C-arm's a lot easier. It's one drape, it goes on, it's a C. The good thing is most C-arms are not that big. So, especially if you get like the mini C-arm, super easy, go straight on. It's just two little spots and it goes right on. During labs, are we going to practice all of this? I'm not really sure which equipment is in the labs. I can kind of find out for you guys if you're going to be doing this, but I do know that when you get to your clinical sites, your preceptors will be there with you because 9 times out of 10, there's a certain amount of cases, certain type of cases that you're going to do. And especially if you do ortho, you're getting a lot of exposure to the C-arm. Okay. But great question. And then again, if you do robotics, then these ones, it's kind of individual. So it's a little bit different because it's just individual, as opposed to this, to me, in my humble opinion, is the more detailed one. Okay. Because of the eyepieces, sometimes there's two, sometimes there's three eyepieces, and you want to make sure that each one keeps sterile. You also do not want to take off the eye piece, let that surgeon do that. So you leave everything intact. So I usually just wrap, if you notice right here, there's like a clear, like a white tape-ish thing. I wrap that around the eyepiece and I just leave it and let the surgeon take that off. Okay. The other thing is removing the drapes. Biggest thing is to make sure that there's all instruments off of the field. You don't want to have any instruments in there that could potentially get tossed, especially sharps. So the first thing we do is we remove all of our sharps, all of our countables off of our field. And a lot of times when I'm in the lab, I'll say things like, drapes are coming down. First time. A lot of times you do not get that courtesy. You'll notice they just start seeing the surgeon start pulling the drapes down, okay? And they're rolling them down. One member of the sterile team does hold any dressings in place. So right there, skin incision is done. We've handed up, incision is closed. All of our counts are complete. We've handed up the dressings, and one person will keep a hand on the dressing as the drapes are coming down. It's usually their assistant, okay? Or the other surgeon that's in the room. Drapes will come down, get rolled out. Your circulator, it's really awesome. They're going to have the trash receptacle at the end of the bed because you have already moved all of your equipment out of the way. Okay. Instruments are off the table. Um, Everything is good. Drapes come down, go in the trash, and you stay sterile usually. Normally I ask permission to break just because you never know. A lot of ENT cases, especially with tonsils, I will stay in the room and I will have my stuff open, ready until that patient is in recovery because they can bleed out and come right back into the operating room. And then we've got to go in and coagulate um, the blood vessels. After prepping the surgical room and everything, do we re-scrub in new gloves and gowns? So you will stay sterile. You're not going to be the one, great question, by the way. You're not the one actually doing the prep. You are scrubbed in. So everything works simultaneously. Anesthesia is working on the patient as far as making sure that they are intubated, doing everything they need to do up top. The surgeon is usually doing what the surgeon's doing. Sometimes they're looking at x-rays, sometimes they're looking at the computer, sometimes they're just going through making sure that the equipment is done. Your circulator is going through getting the prep, doing the prep while you are still setting up your back table. So you're getting your instruments together, you're making sure you have the right amount of supplies, you're working on your Mayo stand, which is going to be your immediate instruments that you're going to use in the beginning. So getting your ray tax, knife blade, Bowie tip, your Adsons with teeth, starting off going small, and then having things you need later as you go through the case. Does that make sense? Does that kind of help kind of put it together? Like everything's happening simultaneously. Okay, awesome. All right. We have, how many questions do we have? We have 10 questions. I don't know if I changed the times. I think they're all still 20 seconds. Let's see. If you are able to join, please do. If you're not, don't stress. You can just write in the correct answer. But what I do want to do is make sure you guys have this Kahoot. And again, if you can join, awesome. 10 quick questions, and then we're going to wrap it up. For those of you who are watching, try your luck. Kind of guess as we're playing the game. Okay. Okay, there are 11 of us here. So I'm looking for 4 more. If not, we're going to go ahead and start, and then you guys can just kind of type in the correct color. So let's go ahead and start. Sorry, it always does this, guys. So remember, the skin contains both resident, like normal flora, and non-resident bacteria. Okay, so good job. To prevent wrong site surgery. Yes. So remember, that's that mark. Okay. Remember that surgeon is ultimately responsible, but anyone on the team. This one's kind of process of elimination. Yep. Injury of the sphincter muscle. Okay. Okay, so this one was from the book, okay? When we're doing our skin prep, we're going in a circular motion. So is that mechanical? Mechanical, mechanical. So pooling, okay? Remember those white drapes I showed you? We put those down to kind of get that excess fluid, okay? Exactly. Get rid of it. When in doubt, throw it out, okay? When in doubt, throw it out. And that's for anything in the operating room. Sorry, I skipped that one, you guys. Which one is not a step in the draping process? Applying antiseptic solution after draping. We're not placing anything that. Sorry about that one. Okay, sorry, y'all. That totally just happened. My computer just went crazy. So we're gonna hurry up with this. I'm gonna make sure you guys have the Kahoot to get the last two questions. Um, again, the questions were the last two because it's showing it now, but the last two, wire surgical drapes extended beyond the incision site. We want to create freedom to be able to kind of like move. Okay. We'll go to the next two questions quick because my computer is acting up. So you guys won't answer them. I'll just go through them real quick and then make sure you guys have the Kahoot so you guys can kind of play with against each other. Um, Single patient container. What type of container should be used to hold antiseptic solutions for skin prep? A single patient container. Okay. And then the very last one that we'll go through really quick. When should surgical drapes be removed? And after the incision is closed and with the care to contain any fluids. So we're kind of rolling them, making sure that anything that is gross or like extra fluid doesn't get all over the floor. Okay. That was really crazy. Sorry about that. So, what did we cover? Our quote of the week: you may encounter many defeats, but you must not be defeated. In fact, it may be necessary to encounter the defeats so you can know who you are and what you can rise from and how you can still come out of it. For those of you who are watching, describe the risk of urinary catheterization, explain the rationale for surgical prep incision, and what techniques are used to prevent contamination of the gloved hands while draping the patient. We covered a lot in today, getting you guys ready for the next step. From here on out, it's going to be building on the foundation to help prepare you. Once we get to week 8, I'm going to be introducing you to some of the things that you're going to be utilizing in module 4. Okay. So Be on the lookout for that. We are getting closer and closer to finals. With that, if there's something particularly you want me to kind of break down and cover, please, please, please reach out. I encourage you all to keep pushing forward. I look forward to seeing everyone who can attend Wednesday for ST310's live session. With that, you guys have a wonderful rest of your evening and good night.